the hour?
We have just about 1 minute.
Okay.
Hi, everyone, for who's joining us. We're going to get started shortly. If you can just please go ahead and make sure that you are muted. If not, I will mute you, but it's always easier if you do it yourself. But thank you so much for joining us. Okay, well, we'll go ahead and get started. I think we have about 1 minute left, but I'll take this time to introduce our wonderful speaker, Ms. Connie Dahlin. Always a pleasure to have her join us. And so for those of you who haven't met Connie yet, which I think is almost just about all of you, but if not, just a little introduction. Connie has extensive administrative, clinical, and academic experience in hospice and palliative care across the health continuum. She is the co-director of the Palliative Care APP externship and a palliative nurse practitioner at Salem Hospital, as well as a consultant to the Center to Advance Palliative Care in Community-Based Care and Education. She also serves as an adjunct faculty at the University of Maryland Graduate Program in Palliative Care, as well as the MGH Institute of Health Professions. She is a fellow of the Hospice and Palliative Nursing, as well as the American Academy of Nursing. And then in 2018, she was recognized as a visionary in hospice and palliative medicine by the American Academy of Hospice and Palliative Medicine. And then in 2022, she received the HIPNA Distinguished Practice Award. We are always so grateful to have Connie join us with LNEC. And so today she will be discussing expanding palliative care communication skills. So without further ado, a big round of applause for Connie. Thank you.
Well, good afternoon. I think it's safe to say good afternoon, everybody. Really thrilled to be here. I want this to be useful for you and helping you think. I'm really thinking about the title of my talk being Expanding Palliative Care Communications Skills. And so, you know, I mean, I think we think about communication and this two-way street. And, you know, a lot of things that we thought about communication have sort of been amplified by the pandemic. So I really wanted to go over today, like what's in a relationship, what are some of the things to think about, what are some of the regional things when we think about communication, because there's a lot coming out. And so this is just my distillation of some of the literature, but happy to have people kind of jump in. So I think, you know, when we think about a palliative care communication as a nurse-patient relationship. I'm going to use the word nurse for this. I don't know if there's other providers, but I'm just using the nurse part because that's where I'm speaking from, but I think it is similar. You know, as much as possible, I think rule number one is to find a quiet, calm environment without distractions that make communication easier. Now, I'm based in a hospital. I know sometimes that's not possible, and you do the best that you can. If you're in an outpatient clinic, hopefully you have a space that you can talk to people. I think, you know, when I did outpatient care and I would be asked to see a patient and they were in the chemotherapy room and they were just separated by curtains. You can imagine there were things that I said, I'm not going to really talk about that because I really don't want that to be a public forum. So thinking about that. And then obviously in the home, trying to think about, you know, do they have space? Are their family hovering? How do we have some space for the patient alone? I think making sure that, you know, timing is okay for the patient. Sometimes I just watch this all the time happen, at least in hospitals. People go barging into the patient. The patient's sitting on the bedpan, or they've just been vomiting or whatever. They've had a rough night. Like, they might not be in the place to really have a good communication part. If it's an emergency, obviously might need to do it, but if it's not, we might need to come back. I think the whole part of using respectful and inclusive language, I think we know that there's so many pieces about healthcare, and older patients kind of get nervous and deferential, and younger patients are trying to make sure that we're including them. So not making any assumptions. introducing ourselves by our name, our title, our role, and our pronoun, which may be more of an urban thing. I've been doing a survey of my colleagues regionally to kind of talk about what are the things that are important. And in some places, it's their name, their title, and if they're part of a parish or a religious part, or if they're in a rural area, it's their name, their title, and where they live in the community. So you have to think about the culture, about where that is. But I think also constantly reintroducing yourself, because patients are introduced to so many people. They don't remember who we are or what we do. And so that can be really helpful. Making sure that we're pronouncing the name correctly. There's nothing worse than going through a whole encounter with a patient. At the end, they say, I just wanted to let you know my name was wrong. And so asking them in the beginning, Mrs. Smith or Mr. Delara, is your name Delara or Delara? And what would you like me to call you? And again, if they have a preferred pronoun. One of the things that I've been thinking about recently is I just had a healthcare encounter, and it was an outpatient clinic, and it's a real challenge, right? Because calling me by my first name seems kind of weird. Calling me by my last name obviously is a HIPAA issue. Giving me a number didn't seem like, so we're in an interesting place about how do we both be respectful and think about what we call that. And then thinking about when we're in the encounter that we're going to demonstrate and reflect sensitivity, if people are telling us about their sexual orientation or gender history, and that some people won't feel safe until they've really trusted us. So there's a lot that goes into that. I think, asking the patient their preferred language, if English is not their preferred language. And do we need a translator? And, sometimes what happens is family will say, here's what's going on, but, knowing that we shouldn't be using families as translators. So in-person translators, are they available? Virtual translators, I think that's been really amplified by the COVID pandemic. And so people have a lot of that. But I can tell you, I work at a safety net hospital. So I am still using those 2 blue phones where you pick one up and you call an operator and you ask for a language. And there have been times recently that's a little embarrassing because I'm going through 5 operators before somebody knows what palliative care is. And that is always uncomfortable for me because it means that what does it say to the family that I can't find somebody who knows what palliative care is, and that I'm going through so many people. So it's an interesting part. And then I kind of have to reestablish that, this is a conversation about serious illness and doing that. So thinking about this translation piece is important. I think also acknowledging any individuals who are with the patient. I was just talking to my father-in-law, who has been in the hospital, and he has what he would call a woman friend. And she has been inserting herself at some of the healthcare things, and she's not his girlfriend, and she has no family part. And we were trying to say, you can ask them to say, I'd like some time alone with the clinician. But also as clinicians, we need to ask who this person is, and then ask the patient, do they have permission to stay or not, or is it appropriate, so that it's not feeling awkward for them to ask, but it's coming from us. And then I think going into an understanding of what the patient understands about their situation. And then we're going to go into a formal history. But I think the reason why I bring this up is because there's been a lot now in the literature about how do we just set up this comfortable relationship. And, I can say that it's really different when I'm in clinic and somebody has an appointment with me versus when I'm walking into a patient's room who in the hospital, who may or may not know or they might not know why, or they're not cognitively there, so there's a lot of different pieces. And then, obviously if I'm going into a long-term care setting, that has its own implications, because I always make sure that I'm talking louder for some of these people who can't hear, which also then is, I'm trying to shut the door so the whole hall doesn't hear what I'm saying. But also knowing that I really have to slow down for some of my older adults if they can't hear and they can't follow. So just thinking about that situation. So I think, when we're trying to learn about what the patient understands, What do they understand? And then what if those make sense? And you've seen this in cancer care where they said, oh, the team told me I'm okay, I just have a tumor, and they don't understand that a tumor may be cancer. And then also, how are they feeling? Because sometimes they might have had a whole experience that we don't understand. And so kind of thinking about that. And then our body language. I think this whole part about good eye contact, open posture. I'm one of those nurses that sits on people's beds because I feel like it puts us at a level and then they know that I'm making a commitment to sit for them. I could sit in chairs, but where I'm often there are not chairs, and I don't really like sitting on commodes. But again, sometimes, I'm also leaning down by the edge of the bed to change some of that eye contact level, particularly for my older adults, so that they are kind of in a power position of looking down at me. And then looking, to avoid medical jargon. And I can tell you that my spouse is a psychologist, and he just laughs at me because he says medical language, you guys you slip into it so quickly, and having to slow down that. So he's sort of retraining me to use some of the common language, which I think is important. Thinking about, when patients can't, when you can't speak their language, what are the different things, what are some key phrases depending on what the cultures that you're serving, like so food and water and toileting and pain. There's also a lot more of free websites out there created by UCSF, so it's a little better. iTranslate has a whole HIPAA thing. Google Translate, which might not be great, Verbal Care, Speak and Translate, and Care to Translate. So I think we just need to be aware of some of these apps, because if we have a younger population, they might be wanting to use them, and it might be easier sometimes than getting a translator, or we might need it before we can get a translator. Making sure that the patient are understanding what they've been told. And I think, when patients are talking to us, we need to be clear that we didn't understand. Sometimes I have patients where they're talking and they'll tell me a whole story, and I'll be like, okay, so help me understand, what was that story about, or how does that relate to our conversation? Because I may be missing what it is they're really trying to tell me. And I think, the challenge also is that, at least here where I am in Massachusetts, we're still wearing PPE in the hospital. And, I am very aware. I feel like I have to yell sometimes to make people hear me. And it's just because, we're talking through all those pieces of equipment. So thinking about how do we make that better. Patients have told me, however, that they're still reading our facial expression. So even if it's from here, they're reading our eyes, they're reading our body language. So remembering that we're communicating no matter what. Again, when patients have difficulty speaking, so aphasia, one of the things we need to do sometimes is reduce the background noise and other distractions. So closing the door, trying to turn off the TVs next to us, or have people use earphones, giving people plenty enough time to speak. And that sometimes is hard if we're in a rush. Trying not to interrupt or finish people's sentences. I was recently with somebody who was a friend of mine, and I wasn't quite sure what was going on, but I would get halfway through sentences and they were finishing them for me. And I'm thinking, what if that wasn't what I really wanted to say? So it was just something to remind myself of. At a certain point that can get sort of annoying. Looking at people when we're speaking so that they can be reading our lips if they need to. Again, being honest if we don't understand, because if we pretend, they can see it as that we're being patronizing or upsetting to them. And then, really using letter or picture boards or symbols. And again, some of the phone apps have really increased things. Again, people with hearing loss, remembering that one of the challenges, particularly with COVID, is that people with hearing loss who are lip reading haven't been able to see that. And so when at all possible, letting us see their face, trying not to exaggerate our mouth movements, sometimes using sign language. I one time had a situation where I had a couple and they used different sign language. So actually I had to have two different sign language interpreters. And I can tell you it was one of the interesting things, because I'm trying to look at the patient and there's one sign language person over here, and then the husband is over here with another. And so it was like a little figure eight. And I had to keep reminding myself, just look at the patient and let all of that translation and hand movement happen, and try to keep focused. Sometimes people are doing finger spelling, written language. So sometimes people can still use writing boards. And speaking at a normal volume, because shouting can be really uncomfortable for people wearing hearing aids. And I've had sometimes where family members adjust the patient's hearing aid, which is a problem, right? Because they might not have sensitive things to that. So just make sure that people are wearing their hearing aids, making sure that it's at the right setting, and making sure that batteries work are always important. People with vision loss, it's really important for us to communicate, and sort of thinking about how important our voice is. And remember, our voice conveys a lot for people who are used to just listening. We may think that we're not coming off with a frustration sound, but in fact, it might sound more frustrating. We might be talking too fast. We might be talking too loudly. But it's really important when we have people with vision loss that we let people know we're there, and that we're going to start a conversation and where we are in the room. And then, really helping people with vision loss, asking how they prefer to communicate. Are they wanting to use Braille or audio? We might need to check in more, and they might want to use magnifiers and tablets. So really thinking about, again, also what your resources are. Sharing information is so important with our patients. And so again, telling them why we're there, if we're going to be giving them medicines, if we're doing personal care, if we're going to have a conversation, thinking about their health literacy. So providing information in the way that we can understand. I've done a number of medical missions in countries where I did not speak their language, but I can tell you, when I was doing medications, I used pictures of the sun. So a sunrise, middle of the day, late part, and then moon and the stars for nighttime, for helping give education about medications. And also thinking about what were important in that culture, of how I could be doing teaching. But writing words down, again, using pictures and symbols, and making sure people can tell us what they understand. Giving people booklets and websites are so important. I think sometimes people think, oh, in this tech age, let's just have them go to the website. But in a lot of rural communities, people don't have access to smart devices or any of those types of things, or they might not have broadband internet access. So, I think written materials are really helpful, and then they can review some of that material on their own time. Thinking about patients with intellectual and developmental disabilities. This is an area that in palliative care, we haven't done as much work on it. And so what the challenge is that we have specialists who have a really good work with patients with intellectual and developmental disabilities, but they have limited knowledge about palliative care. And then we have us with great knowledge about palliative care, but less about the intellectual and developmental disabilities. So really having to think about, what are the communication strategies? Is it verbal communication? Is it visual tools? Or having patients bring some of the things that they help to express themselves? And I've given you some examples of Books Beyond Words, which is 26 picture books. Getting On with Cancer, which again has been written specifically for this population. And I think another strategy is to show people of an image of somebody in a similar situation and ask them, what the fictional person might want. So they might be able to say what that person wants, which might be what they're wanting. I think the other part is remembering, with all of this, it's a team process. I had a young man who had cerebral palsy, and he came in with cancer, and his family had done an amazing job for his 40 years of making him be able to live as fully as possible. They were from Maine, so they had rebuilt a boat so that he could kayak. They'd rebuilt a sail. They'd rebuilt his bicycle. He'd been in a work program and had been sort of this model person. And so everybody was afraid that he wasn't understanding that he had cancer. And in fact, he was. The sad part was that when he got to the more progressed, he was in the hospital, and we had to decide. We were doing a J tube for him because there was a lot of GI issues. And I can say to you that one of the amazing parts about that was that I ended up talking to the mother and the sister saying, you've done a great job with him, and we're at a different place, and you've spent all this time keeping it, and it may be time to let him go. And the chaplain went in to talk to him, and he revealed to her that he was very aware what was going on, and he didn't want to burden his family. And in fact, he was okay with no more treatment. And it was just one of the most beautiful encounters of interprofessional care. And what happened, the sad part was that his group home that had taken care of him for a number of years would not take him back. They felt like it would be too sad. And I was thinking, okay, this is interesting because he's disappeared. Don't you think people will notice? But it became clear to me that they couldn't take care of him. And so we kept him in the hospital. And there were people who cared for him over the years who flew in from all over the country. And we made his room as homey as possible. And, he had a very peaceful death that his family felt good about and the staff felt good about. We used multiple communication with him, but it was just one of those beautiful things. And then the chaplain and I were at his funeral, and the chaplain ended up doing the funeral for them. And they were just so grateful of the process of the multi ways that we communicated. And so it was really one of those lessons about taking the time and slowing things down and making it individual helped. There is, I found this disability distress assessment tool, which was developed to help clinicians and caregivers and communicate an individual's signs of stress and contentment, because we know families know patients best. And then there's the Abbey scale, which is another simple tool for people who can't communicate well. And so again, it's looking at expressions for pain management in pediatrics. There's also the ARCH model, which is ask, keeping questions straightforward, find out what they know, what they want to know, repeating and clarifying, checking the level of understanding, and then helping the person to express feelings, knowing that sometimes it might not be a direct way, but they're using other methods. So just to know that we're starting to see some of that in the literature. So I think in summary, we have patients from all different types of backgrounds with different communication skills. So not only cultural, that English is not their first language, but that they have vision and sight and loss, or they might not be able to express themselves. And so we just need to be thoughtful and promote dignity and respect, rather than viewing them as barriers to overcome. And it'll take a little bit more time, but if we take the time and have the patience, it'll be better outcomes. Thinking about our cultural values when we provide care for individuals, and understand how those values may influence decision-making about palliative and end-of-life care. And for me, I think about, we had a woman who came in and she had breast cancer, and you could smell it as she was coming into the floor. And her family was saying they didn't notice, which I found kind of interesting. And then we were making decisions, and it turned out that she actually was part of the Jehovah's Witnesses. So when it came to decision making, we actually couldn't ask her. We needed to ask permission for her to bring in the elders and to have a family meeting with them. And so really thinking about what was that cultural part about who could make decisions and who can't. I know we value autonomy in this country, but when you look at different cultures, sometimes it's either the family or it could be the spiritual leaders. And just being aware of our own attitudes about palliative care and end-of-life issues for people with hearing and vision loss and disabilities. A lot of times they understand everything. It's just a matter of making sure that we're able to have a really open conversation and go into the detail that they may need. So with that, I am going to open it up for questions and discussions and stop sharing so that I could see all of you. And wonder if that's brought up any ideas or thoughts for you. Oh, I love this. I cringe when a nurse addresses a patient as mama, papa, honey, sweetheart. That is really important, I think. And I have been watching that and have been curious. I think sometimes it's coming out of a place of a good place, and perhaps being endearing. But I noticed when somebody said that to me as a patient, I just cringed. And it was one of those moments where I was thinking, okay, here I do this. How do I say to this person, please don't say that to me without insulting them? And so I just thought, oh, I think I came out and said, it's okay to address me as Connie, because it was like, okay, I didn't want to be sweetheart. But I'm curious where we have done that, because for some people, I wonder what they think when we do that. So really, really good point. Thanks for bringing that up. Other comments or thoughts or situations that people have had that they were not sure what to do, or they felt were really successful and they want to tell people about something that went well?
Hi, this is Kathy Olson. I'm not on video, and because I just got home from the gym. One thing I remember from a language barrier perspective is our facility used the blue phones, also the two-handled blue phone Cybercom phones, and we would usually put it on speaker and just have the interpreter speak for us through the phone. But the patient spoke Spanish and he spoke minimal English, where he would say yes, yes, and shake his head, but you weren't sure what he was getting. And all of the other nurses that I worked with, this is before I became an NP, were like, oh no, he said he was fine, and just made the assumption that he understood what they said. And I think I was the only one that used the phone, and I couldn't understand. I'm like, how can you do an assessment on somebody when you're not really sure he's getting what you're saying?
Right.
So I just like I don't, just because he can nod his head and say yes doesn't mean he's getting what you're saying.
And that's a great point, Kathy. And I think having the conversation, I remember when you're using any of the phones or the interpreters, the best case is that you have some time alone with them to say, we're going to have this conversation. It's a difficult conversation. Here's what we're going to talk about, so you can prepare them. But I think, when I've had that situation, I've asked the interpreter to say to them, to the patient, asking them, what do they understand, why they're in the hospital, what's been going on, what do they think is going to happen, just so that I'm kind of getting a sense of not the yes, but what do they really understand? And sometimes families won't tell patients, and so they really don't know anything. And that can be hard, because then do you talk to the patient without the family, or do you just have more of a conversation? But I think you're right. Trying to use those phones. And I tell you that I'm still using them, just so that we remember that, even in the spite of using the iPads or getting to some of those, A, sometimes on floors, they're being used up, and B, it's, old school, but that, I guess I would say, using the blue phones is better than nothing in that moment.
Hi, this is Pam. I just typed something in the chat. I visited several patients that were handicapped, and they just had observers, which are like CNAs or volunteers, just sitting there with them. And I would go in to engage them, and they were just sitting there, and I actually have to say, I did go into one room where one was really engaging with them. But I thought, after hearing this presentation, I was like, wow, they weren't even communicating with them. They were just sitting there to make sure they didn't fall out the bed. How
Right.
How does that make them feel? Just someone babysitting you to make sure you don't fall out the bed, but they're not really engaging with you.
And so I think, that's a great point, Pamela, of like, when we're going in, I sometimes wonder what people think when I'm walking, because I'll walk into the room and say, I'm Connie Dahlin, I'm from palliative care. I'm here from the team. The team asked me to come. The person could be comatose, and I'm still saying, this is what I'm doing. I'm listening to your heart. I'm sorry if my stethoscope is cold. I'm going to be touching you, because if people can't express back, I just want to prepare them, as if I were doing with somebody with cognitive impairment, what I'm going to do to prepare them, right? Because I don't want them to feel that I'm intrusive, and B, that calm voice of sort of saying what I'm going to do, I think is, my sense must be more assuring than me just coming in silently and doing my thing, right? So I think sometimes it's helping the CNAs sort of have a conversation, or even if they're turning on the TV, to sort of say, hey, what do you think about that? Or the music, or just being respectful that there's a being inside of that. I did have a patient recently who was Russian Orthodox, which we have a large community here, which is always interesting when we get consults to do for hospice and palliative care, because culturally that is not something that they would usually want. So it necessitates a conversation. But I went in there and it was like, okay, I need a translator. And so I had the translator, a video translator, who could see her. And it took about 5 minutes. And she said, I'm speaking Russian and asking what you're saying. And she can't follow at all of what you're doing. And so, I can tell her what you're doing, but I just want you to know you're not going to get much back, which was kind of reassuring to me. And then I went to the staff to say, okay, we have a person here who is not quite cognitively with it. And then we have probably a whole cultural part that we can't even explore. Can we sort of stack some of our communication so we're not going in so many times, but maybe going in once a shift to do some of the concentrated communication, just so that we don't stress that person. So that's also something, Pamela, that you could think about too, of how to be respectful in that way. Let's see. A. Smith says, speaking of culture, it's important to remember that different cultures have different norms about eye contact. Yes, I'm very aware of that. I love sometimes, if you want to test that out, when you're on public transportation, of seeing how much, you're supposed to be looking or not. And there are some places where you wouldn't, because that's sort of an aggressive type of thing. So sometimes I'm watching family members or watching some other times. As you make me think about that, I don't think I've ever asked somebody if it's okay if I look at them directly. That felt a little too direct, but I'm trying to figure out some of that. So that's good. Carol says, I'm a habitually loud talker, 5 siblings, and my dad had horrible hearing due to factory work. I have to be so aware, because I had a patient who stopped me and said I was yelling at her. And I was like, thank you for bringing that. That is such an important part, remember, because there was a tendency in past generations that if somebody didn't speak English as their first language, you yelled at them in English as if that was going to make it better for the translation, rather than saying it's not about that they can hear you, they just don't understand some of the words. I think the challenge comes that you do have some people who hear louder and higher pitches. And I'm constantly then really thinking about, obviously, as I said, if I'm in a clinic, I'm going to shut the door no matter what. If I'm in the hospital, do I shut the door just so that everybody's not hearing, and I can pretend that I'm having a little bit more of a conversation, because I'm sure some people will hear some of that. But I think, it's okay, maybe, Carol, since you have that, of just kind of naming that for somebody, to say, I know sometimes my voice may be really loud. Tell me if this is a comfortable pitch for you. And so you're just putting it out there, and they can say yes or no. But it's also really nice of you as self-awareness to kind of honor to say that. I've had some people say to me that I have a very low voice. And so I have to really work to kind of make it higher. Because again, as I told you, sometimes I feel like I'm screaming, and they're like, could you repeat that? I can't hear you. So, it's kind of a funny part. And then also it may be different, like if you're in the ICU and you have all these pumps and stuff, there's so much background noise versus being in another setting. So, Carol, I think that's great. Mary says, we use a video interpreter frequently with our patients who do not speak English. It's been very helpful. But I love the helpful hints about and books that you provided for visual hearing and learning. I think that's the whole part about sometimes it, I know with COVID, people donated different older iPads, or they were able to buy them, but that's for resourced areas. And sometimes you can't get them. So it's still worth it to let people be writing things down or drawing pictures or have a picture board so they can do that. If you've worked with ALS patients, it's pretty stunning when you have somebody who's had enough time to use an alphabet board and they're going through and blinking at every fifth thing and the family picks it up. It's stunning because they're able to go through and have that person communicate. I will say there are times when it can be incredibly difficult. I had a young man who had a traumatic brain injury and couldn't talk at all. And there's a real question of goals of care. And I want to say we have a lot of families here in Massachusetts from Cape Verde. And so I think there was also this cultural piece. And I remember going in to talk to him and thinking, I've got to look in his eyes and look at the soul of his eyes. And because I couldn't do yes, no, because he couldn't do that. But I still had a conversation with him as if he could hear me, because I was curious if he was locked in. I didn't want him to think that I wasn't including him, but it was really hard, right? Because I wasn't getting any of that feedback. And so I think, I have tended all of the time to be talking with people, even if I'm not quite sure, for saying comments like, your family's struggling with what to do with the right thing. And we're just trying to think about, your personality and what you'd want and your values to, your family really loves you and wants to do, just sort of naming some of the pieces that are going on so that if they are picking up any, this is going to sound woo-woo, but kind of energy from us of like tension or something, that I'm trying to explain it and kind of be inclusive of them. Because I do think, when you walk into patient, something to think about. If you're kind of set for a visit and you walk into a patient and you have a conversation and you walk out really down and depressed, that can be an indicator that maybe the patient is depressed. And so doing more of an interview for that. The same thing is if you kind of walked in and okay, and then you walk out really anxious, then that patient might be really anxious. So kind of using our limbic system sometimes also to be kind of picking up some of what's going on with the patient, whether they can speak English or not, because sometimes you can have people who can't name their psychological distress for some reason, but you're kind of picking up on some of that. So just kind of using all of your nursing assessment skills can be really, really important. Other thoughts or comments or situations that you all have come up with that have made you think, or situations that you might get in that you would be trying to think about? Rhonda, I'm going to ask you, since you're a chaplain, if you have any thoughts on communication that you think we could learn from you, that you've learned from some of your skills.
That's sweet. Yeah. Thanks for asking. I think I was tracking with pretty much everything you said. I know one thing that chaplains are taught is to read the room as well as the person. And I think you've kind of hinted at that too. I know I was called to see a patient once, and the nurse told me before I went in that he was very anxious, that he asked to see a chaplain, that he was not doing very well emotionally or medically. I go into the room. I had a student chaplain shadowing me, and he had little religious statues and a really big cross, around his neck, and he was very anxious. And so before he left, I said, sir, we're going to have a prayer with you. And the student said, why didn't you let him ask for the prayer? And I'm like, you got to read the room. The signs were all around that would be a comfort to him. So it's not always, as you say, what people say, but what's around them.
Yeah, no, that's lovely. Thanks for sharing that. I think, and that's in this time, I think with COVID, it's been hard because people can't bring in as many things. And so sometimes we don't have some of those symbols that they've been allowed to bring in because of, the fear of them transmitting any diseases and stuff. But that's really great of how to think about that. I used to love rounding with a chaplain because I just loved watching what they were looking for and thinking, okay, I know they have their role, but are things that I could be asking ahead of time. And so, Rhonda, I will confess that I one time had a woman who was from the deep South, and we were having a great conversation. And in the middle of the conversation, she looked up at me and she said, "Are you a Christian?" Now, you have to remember, I am now living in New England, and religion is kind of one of taboo until like second or third layer. And I'm sitting here going, okay, am I Christian? Did I do this? Have I done anything wrong? I'm going through this whole thing of like, how do I answer this question honestly? And how would she define it? And finally, my face must have revealed that I was kind of going too deep. And she said, "I just want to know if we can say a prayer together." And I burst out laughing. And she just said, "What are you laughing at?" I said, "Because I was going to this whole other, philosophical part." And she said, "I could see that in your face." And we just had a lovely conversation after that. But it was really kind of a reminder to me that it was not that complicated. And she just wanted to have that be that ritual that was important.
It was simpler than it looked.
Yeah. Well, and I think, if you look at, there's been some interesting data about patients do appreciate if we are comfortable as clinicians that we say a prayer with them that they choose, not necessarily that we choose, and how to be present in that way. So I think that that's just lovely, I think, with chaplains. So thank you for that.
Yep, that's a great story. Can I tell you one more story of a
Sure.
mistake I made once? We have quite a few Spanish-speaking patients. I'm in a city, Baltimore, and I saw that the name before I went into the room was a more Hispanic name, right? And so I asked the nurses. I said, "Oh, do I need to take the translator in? The iPad or whatever we had at the time, or how is his facility with English?" And they went, "Oh yeah, it's no problem. It's no problem. He's really good with English speaking, and I know no Spanish." So that particular day, I happened to have one of the oncology fellows shadowing me. So he had on, a white jacket. I did not. So when I went in, I introduced myself, and he immediately began telling me in pretty good English all of his medical problems. Of course, it took me a minute. He was reading my room. I was with a doctor, and he didn't understand chaplain. And the fellow was very kind. And of course, we saw what was happening. And he said, "Just a minute, let me get the iPad to translate." And so, of course, the patient was a little bit embarrassed, that he had told me all about diarrhea and all these terrible symptoms. But we did kindly use humor to go forward. So that was my mistake, right? I didn't really check it out very well. And he read my room. He read the room that I came in with. So, it's going both ways, right?
Yeah, no, I think that's great. I think that's really important, just thinking about that and what we come in with. I think patients, I have learned so much from patients who say that, what they are totally reading us as we walk in the room. Are we calm? Are we rushed? Particularly like in the patient care room in the hospital, they can tell, like, do we go to the side of the bed to say good morning or not? Do we put sheets and walk out? I mean, there's a whole bunch of stuff that we're communicating as we get ready to sort of engage, and that they are paying attention to that and can kind of look at that. And I think, some of this has also been written up. If many of you have heard of Balfour Mount, who started palliative care in Canada, and it moved, and he himself became a cancer patient. He had esophageal cancer. And I think one of his things was that he had taught all these medical students how to communicate and be at the bedside. And, they'd then kind of grown up. And then when he was sick, they were talking at the end of his bed, they were talking at the door, and he was really experiencing this part of feeling pretty alienated from a team that he had really helped educate. So, I think it's just interesting to think about how we are with just the tiniest of movements, even if it's somebody's scared, and how much we give reassurance. Are they people who want us just to take their hand and say, I'm just here, or are they really somebody who doesn't like any of that? I always try to figure out how much contact people like to be touched, because I'll do their blood pressure cuff. And when I'm doing their blood pressure, I'm using the blood pressure cuff, and I will squeeze it up and I will hold them in my arm with the blood pressure cuff. And I can tell if they pull their hand away, if they really don't like to be touched, or if they keep their hand there, then I realize, okay, this person is somebody who is more comfortable with touch. But I'm sort of doing a procedure to kind of test it out so that I don't have to sort of ask it or doing something like that. So I think, that piece can be really important too. Jacelyn, since you're a social worker, I'm just curious if you have some other pearls of wisdom for us from social work that we should be thinking about or learning from as well. She might have gone off camera.
I know we do have a handful of social workers who might have not labeled their names. So if you are brave enough to want to answer, please feel free to speak up.
Hi, this is Keisha Graham. I'm
Hi,
tuning
Keisha.
in from Charleston. Hi. Well, I will say, Connie, a lot of things that you did say resonate. And I thought about when you were talking about your interaction with people with hearing impairments. I had an incident where everyone was using sign language and we had an interpreter. And of course, the family had their own language. And I just remember the interpreter saying, wait a minute, it's too much talking. But it was, dead silence from my end. And she just saw the look on my face. And I was like, well, right, because they're all, they were talking over each other, but they were using sign language. And when the interpreter said, wait a minute, it's too much talking, I was like the person that was the outside, individual, because I heard nothing. And so then they actually agreed to go and allow the interpreter and I to communicate with the patient. But her sons were there, and it was almost like watching I guess the family dynamics and how the individual that said, she has 5 siblings and they all just talk over each other. And so her kids, although they could speak, but they signed with their mom. It was just very interesting to watch those dynamics. And I think too, when you talked about the individuals with intellectual disabilities, because here in South Carolina, we often, when we run into that, of course, the disabilities boards in those group homes, they won't honor a DNR code.
Wow.
And our correctional facilities won't either. So also when we have someone that's institutionalized in that manner, and we've taken things all the way up to tour commanders, but they will not honor a DNR. So either we're doing a compassionate release, and of course, then they lose all their benefits. And so you're right, usually they end up having to pass away in our hospital unless we can consult with a hospice agency that will be willing to take them as an indigent patient. But we are seeing that more and more with the group homes not honoring a DNR.
Well, and that's interesting that you say that they won't honor I'm not sure if that was about totally the DNR. I just think they weren't comfortable.
With handling the complexity of the
Having
patient.
somebody
Yeah.
die. Yeah, I mean, I think of
Yeah.
it, the other communication that I didn't bring up is when somebody has, serious mental illness, right? And again, we have people who are very expert with dealing with that population, and then we have palliative care. But there was some work that was done like around 2004 to 2006, actually here in Massachusetts, of having collaboration between palliative care folks and people within a serious mental illness department. That kind of has faded, but I think what you're speaking to, Keisha, is we actually need to do that more, right? Because those patients have been with those providers for years. And we need to be collaborating with them because they have that relationship and trust, right? And then we need to be helping teach them about what does it mean to think about some of those decisions. And you rightly bring up if they have guardianship or anything like that, it can get so complicated as to what decisions. And then you feel like you're talking with the patient and the family if the family's not been designated as the guardian. And then you have this whole legal group that talk about really strange communication, which you know better than I.
Yes, ma'am.
It's really kind of, crazy, I think. And I think the other thing, Keisha, that you make a point of is that, these conversations take time, right? You go in thinking we're going to do one thing, and then you have to pivot and say, okay, wait, we got to start all over. And here's how we have to start
Yeah.
from.
Yeah.
And being patient with that. And I know sometimes in our health systems, there's so much going on, and we're nurses. We like to get the task done and wrap it up. And sometimes we can only just kind of figure out putting on the gift wrapping paper, and we're not able to kind of pull those pieces together yet, because that's just not going to be there. But thanks for bringing up the incarcerated population and that, because I think we do need to pay attention to that more. And depending on where you are, you're going to have more exposure to that. I find that hard. I guess I don't see that. It would make sense. I was just going to say, at the safety net hospital that I work in, we're not seeing that many, but it would make sense because the bigger jails are downtown. So you're going to see those patients downtown. And you want to talk about really fraught communication. The few times that I've had somebody who is incarcerated and they are handcuffed to
Yep.
bed, and how do you have a conversation when a guard is listening and they're not going to want to be vulnerable, right?
Right.
And
Right.
sometimes you're allowed to ask the guard to leave or not. I mean, it's those ones are really hard because the information that you're getting, or trying to be respectful, not put them in a vulnerable place. It's yeah.
And the guards, I mean, of course, they have a job to do, but even entering the room, it already sets up a precedence. Like, you got to sign your name on their papers and identify who you are. And so they take notes about the time you're entering and the time you're exiting the room. So it's really complicated.
It is complicated. And then just our stress of thinking about, okay, how do we have those conversations and using the same, because sometimes you might have people who are incarcerated who don't have a high health literacy or literacy at all. I mean, so you're sort of having to use those same principles, but then there's just even a more difficult dynamic. Yeah, that's great. Thanks for bringing that up. Other comments or things that people thought I was going to talk about that I didn't bring up that you might have questions about, or just other challenging situations? Anything else you want to put in the chat?
I will say this before, we wrap up, because this is always the type of person I am, is that if you think of a question for Connie after we wrap up this webinar, please feel free to shoot your question or comment to me, and I'll make sure she gets to that, because my great ideas always pop in as soon as we log off. So if you're like me, please do not hesitate to reach out.
And thank you all for attending. I hope this was helpful just in thinking about another way. I think, I acknowledge that we're all really busy and some days we're better at this than others. And our patience level is, just at a different place. But I think part of it is just kind of, thinking about, as we go into the room, are we making it possible for the patient to be able to communicate their needs to us rather than us telling us what we need them to do? And just when we think about some of these settings, hospitals for some people can just be anxiety, right? They lose all control, they lose all dignity. Whoever created Johnny's, like, what were they thinking? And then when you're in a clinic, that there's so much busyness and they know that it's time limited. And so that can add to their stress of remembering all the questions. In people's homes, we're sometimes there. I wouldn't even say that we're a guest. I would say that we're a visitor that have a job. Sometimes they haven't invited us and they don't want us. And so how do we connect with them there? And then in long-term care settings, it's just a whole different culture, I think, depending on where people are. So, some of the places where I think about practicing this is like in less threatening places. So if you're working with people, senior centers or adult daycare centers, adult health daycare centers, or pediatric health daycare centers. And thinking about also, like, as we look at pediatrics, what is it they do so well, whether including the family with the patient, right? Of saying it's a unit. And so, how do we bring that unit in, both by still honoring the patient, but understanding that there's often people, whoever is defined by the patient as family, surrounding that person, and they're going to be influencing the care. And so what do they need to be making decisions? And when I am working, there are times when I just say, okay, my goal for today is I can't fix all the things that are happening, but I can be going into the patient and offering my presence and respectful time. And I have been sort of amazed recently by people that, a couple of people that I visited in the ICU, and I did not honestly fix anything, but I took time to listen. And they would say, thank you. You have spent the most time with me to really hear me. And part of me, that's lovely for them to say, but part of me is saying, wow, that's really sad that we actually have people with healthcare needs and we don't kind of listen to them of what their experience is, and realizing that that will influence, some of the outcomes. And so that's sometimes where I just try to ground myself of, if I can only do anything, how do I borrow from some of my chaplain and social work and psych CNS friends to say, before I'm going into the room, to just take a deep breath and breathe out, and then say, how can I be present for that encounter? And that's really hard to do. I'm not saying that if people aren't crazy busy, but if I can take that part and just center myself, that maybe that I will kind of come out with a little bit of better communication at the end. So I hope that's helpful. And again, if there's other thoughts or comments or things that you think I need to rethink or do whatever, please let Haley know. And thank you for coming, and thank you for all the work that you do and being there for your patients and families. I know they appreciate it, and I hope that it also brings you satisfaction and feeling like you make a difference.
Thank you so much, Connie. That was wonderful.
Great. Thanks, everybody. Take good care.
Thank you.
Thank you.
Thanks.
Just a reminder for everyone, the slides that Connie used today will be posted on your Dropbox for ICC, and then for our EOA folks, I'll send it in the next email for the May webinars. So,
Thank
and if
you.
I forget, please let me know, but you should have all these materials.
Right. Thanks, everyone.
Okay, bye-bye. Have a good day.
Bye, everyone.
Okay.